Okay, so this is the week that we talk about antibiotic therapy. This is always a week that everybody wants to talk about, I guess, because antibiotics are so commonly used in primary care, and there's so many different ones. And if you precept with 3 different people, you'll see 3 different choices in terms of antibiotics. That's exactly because there are so many different options, and with rare exception, there's 1 or 2 exceptions, but most of the time there's just several different options that are appropriate for an infection. It's not like there's one right answer and every other answer is wrong. Usually you narrow it down to a few appropriate options, and then you pick the best one based on what the patient's insurance will pay for, how they interact with other medications, what the side effect profile is, and if the patient's uninsured, which one is the cheapest or on the $4 list. So there's lots of different things to consider when you think about antibiotic therapy. My goal of this discussion isn't that you finish it and go, okay, now I know exactly what antibiotic to use for every condition. My goal is that you understand how they work, how we evaluate them, and how you can then determine which ones are appropriate for any given circumstance, and then you just choose the one that fits the patient best. So, the most important thing in Infectious Diseases 101 is that when you want to kill an infecting organism, you have to remember the infecting organism is alive, whether it's bacteria like we're talking about now, or viruses and fungi like we'll talk about next week, or there are protozoans or spirochetes or a whole ton of different life forms that infect humans. They are all life forms, and the goal is to eradicate them without eradicating the human in which they live, because obviously it's kind of counterproductive. Like, you don't want to kill the bacteria if you kill the human in the process, because then killing the bacteria doesn't really matter very much. I mean, I know it sounds like really pedantic, but it's true. You have to figure out how to kill the organism without killing or at least causing significant toxicity in the human host. Bacteria are pretty easy. Actually, in bacteria, there are 3 primary targets of antibiotic therapy, and they are all targets of bacteria that are unique to bacterium. So they're features that bacteria have and humans don't. The first one is the easiest one, and this is the bacterial cell wall. You might remember from Biology 101 in your freshman year of college that bacteria have a cell wall and humans have a cell membrane. Human beings don't have cell walls that surround our cells, and bacteria do. So obviously, the bacterial cell wall, just like the human cell membrane, is the thing that keeps the intracellular environment separate from the extracellular environment. If you destroy a cell wall, the contents within are dispersed into the environment and the organism dies. Just like if you disrupt a cell membrane in humans, the cell dies and that's the end of it. So the bacterial cell wall is a really easy target because humans don't have them. They're constructed of things that humans don't have and don't make. So the bacterial cell wall is a really beautiful target. Antibiotics that interfere with the cell wall can usually be used in just about everybody, like pregnant women, neonates, old people, and everything in between, because they're targeting a structure that human beings just don't have. The second site that we target with antibiotics is bacterial protein synthesis, because a bacterial cell is a really very simple one. Human cells are pretty complex, but bacterial cells are pretty simple. You have the cell wall, which encapsulates all of the elements of life of a bacteria. Inside the cell wall, you have nucleus, and then you have a bunch of protein. All bacteria really is a nucleus and a bunch of protein. There are some small rudimentary organelles, but not at all like human cells. So because a bacteria is comprised almost entirely of protein, if you can block protein synthesis, you block the bacteria's ability to sustain itself. I mean, one of the things with bacteria is that they multiply so quickly, right? Bacteria usually multiply in a matter of hours. So when you get infected with a bacteria, it can multiply very quickly. And then if you can block protein synthesis in the bacteria, you block its ability to multiply very quickly. And that's why patients often feel better really fast when you give an antibiotic. You block the bacteria's ability to replicate itself, which it normally does very, very fast. So humans do make protein synthesis. Well, I don't know if make is the word. Humans are capable of protein synthesis. We do have lots of proteins that do jobs in the body, and so human cells are engaging in protein synthesis every day. The trick is that there are certain features of the process, certain structures that are different in bacteria, and that's what we target with antibiotics. And then finally, bacterial DNA replication is also a target of antibiotic therapy. Obviously, human cells are capable of DNA replication. It's how our cells divide. So you have to be careful. We don't want to interfere with human DNA replication. So there are certain enzymes in the process of bacterial DNA replication that are different from humans. It's a very effective way to kill a bacteria. If you block its ability to divide, it's not going to survive. It's different from protein synthesis. When you block protein synthesis, you block any particular bacterium from the ability to sustain itself. If you block bacterial DNA replication, you block the ability of the bacteria to replicate or to divide so that one bacterium becomes two bacteria. The cell wall, bacterial protein synthesis, and bacterial DNA replication. These are the three primary mechanisms of action of antibiotic therapy. Okay, sorry, I'm sure you heard the phone ring at the end of the last slide, so I got a little bit distracted. Turned the phones off though. But we were talking about the way a cell wall is assembled, and I think the last thing I mentioned from the preceding slide was that beta-lactam antibiotics they bind to this penicillin binding protein that helps bring together those linear strands. So let's see what we got here in terms of pictures. This isn't the one that illustrates it the best, but this is just in general the bacterial cell wall. And again, remember that there are two general types of bacteria. There are gram-positive and gram-negative, and they are gram-positive or gram-negative based upon how the cell wall picks up the gram stain or whether it picks it up or not. You can see by this comparison that gram-positive bacteria have a thinner wall. They're thinner walled structures. It's different, and so this means that the bacteria is going to work differently. Gram-positive, you can see with my laser thing here, you do have an inner cell membrane. I probably should have mentioned that and didn't. Bacteria do have a membrane, but that's not the only thing that separates it from the extracellular environment. So both gram-positive and gram-negative bacteria have this membrane on the inner surface that encapsulates the structures, and then the gram-positive bacteria has an outer cell wall, and that's it. And you can see the label here. These are those peptidoglycan strands. This picks up this, I guess what's a green stain, and that is your peptidoglycan stranded cell wall. Gram-negative bacteria, on the other hand, they're more complex. They have the inner membrane, and then they have that peptidoglycan wall. The wall itself is thinner, but it is surrounded on either side by a periplasmic space, and then the outermost structure is an outer membrane. So gram-negative, the cell wall can't pick up the stain because there is an outer membrane in the way. There is still a wall that separates intracellular from extracellular environment, and because it's the wall that bacteria have and human cells don't, that is the thing that we target. But you do have more to go through here to a bacterial cell wall on the gram-negative side. Okay, here's a better picture of these linear peptidoglycan strands. So this purple thing that looks like a tube is actually, it doesn't look like a braid here, it just looks like a tube. But these are your peptidoglycan strands. So you've got them lined up next to each other, and then they are anchored by these transpeptide chains, these transpeptide crosslinks. And it's the transpeptidation that is inhibited by a beta-lactam antibiotic. Beta-lactam antibiotics have a structure, a physical property called a beta-lactam, which binds to a penicillin-binding protein that is somewhere in this peptide chain. This peptide chain is made of proteins, and again, it's peptide, tetrapeptide, because it's 4 peptides, but it is still a transpeptide chain, linking together these carbohydrate backbones. So anyways, you get the idea. I'm sure if I just stop talking, it'll probably be better. This is the cell wall. This is the way it's structured. In this cross-linked bridge is a protein that binds very readily to beta-lactams. And here is the actual beta-lactam. I know that at least up until this point I've been kind of using the words penicillins and beta-lactams interchangeably. It's because the penicillin antibiotics were the first beta-lactam antibiotics. Again, beta-lactam just refers to the physical property on the antibiotic or embedded in the antibiotic that can bind to a protein in that transpeptide chain. So this is the mechanical structure of penicillin. If you could blow it up and look at it under a microscope, you would see that you have all of these elements that are bound together by bonds. And one of the aspects is the beta-lactam ring. It's a physical property. You could actually crush up a penicillin, stick it under a high-powered microscope, and point and say, oh, there is the beta-lactam ring. It's that beta-lactam ring that can bind to the penicillin binding protein in that transpeptide chain. And when you bind in the transpeptide chain, then that chain can't anchor those linear strands together, and you have a disruption in the integrity of the cell wall. No cell wall, no bacteria will die. So here is the real stuff, like stained and blown up. This is what it really looks like. So let's see. So here is a cell wall. You see the peptidoglycan strands, and they are anchored by these transpeptides, and embedded in them is a penicillin binding protein. The penicillin binding protein is kind of like the receiver. Then in the beta-lactam antibiotic, and right now we're using penicillin as an example of a beta-lactam antibiotic, there is this physical property called the beta-lactam. And the beta-lactam in the antibiotic will bind to the penicillin binding protein in that peptide strand and keep these peptide strands from being bound together via transpeptidation. And then so you do not have a functional cell wall and the bacteria will. So that's how beta-lactam antibiotics work. In the family of beta-lactam antibiotics, we have all of the penicillins, and there are several generations of penicillins. There are narrow spectrum, there are broad spectrum, there are extended spectrum. There's a ton of penicillins. All penicillins are beta-lactam antibiotics. Then we have the cephalosporin family, and there are now, I believe, 5 generations of cephalosporins. They also are all beta-lactam antibiotics. Primaxin, those of you that work in critical care units might be familiar with Primaxin. It's a very broad spectrum. It's probably the broadest of broad beta-lactams. We often use it for people with sepsis when you just don't know what you're trying to kill, but whatever it is, you got to kill it before the patient expires. Primaxin is very broad. It is a beta-lactam. And then Azactam is a beta-lactam antibiotic that is very narrow spectrum for gram-negative organisms. And there are a few other outliers, but these are the primary beta-lactam antibiotics. So when we refer to beta-lactams, we're referring to antibiotics that work by way of the beta-lactam structure, which binds to the penicillin binding protein. And you may hear penicillins, cephalosporins, Primaxin, or Azactam all referred to as beta-lactams because they all work that way. So that's how the antibiotics work. And they kill bacteria. But you know how bacteria are. They multiply very quickly, and like any other living organism, they are programmed to survive. They want to survive. So very quickly, the bacteria that we are killing with these beta-lactams developed an evolutionary protective mechanism referred to as a beta-lactam ACE. Remember that when we put ACE on the end of a word in science, it destroys the first part of the word. So a beta-lactam ACE will destroy beta-lactams. Just like a proteinase will destroy proteins, lipase will break down lipids, and just on and on it goes. The bacteria started producing beta-lactam ACEs because beta-lactam ACEs can kill or inactivate the beta-lactam structure on the antibiotic. If you have a patient with an infection with a bacteria and you give the patient a beta-lactam antibiotic, if that bacteria that the patient has can produce beta-lactamases, then the beta-lactamase will inactivate the beta-lactam structure on the antibiotic. The antibiotic will not work. It'll be ineffective. The patient will be resistant to it. And that's it. Patient will expire or maybe just stay sick. The antibiotic is rendered ineffective in the setting of beta-lactamases. When this happens, the patient is resistant to the antibiotic. The antibiotic is said to be beta-lactamase sensitive. Now that's one of those lines that everybody will nod their head and get confused by it. So I just want to take a minute to clear this up, because remember, the goal at this level is that you really understand what we're talking about. If you have an infection and I give you a beta-lactam antibiotic and your infection makes beta-lactamases and those beta-lactamases inactivate the antibiotic was sensitive to the beta-lactamase, right? Because the beta-lactamase did stuff to it. It was sensitive to it. The patient, however, is resistant to the antibiotic because the antibiotic won't work, because it was inactivated by the beta-lactamases. If you're struggling with that, take a few minutes to replay it over, listen to it again, or whatever. You do want to understand the difference between being resistant to something and being sensitive to it. Sometimes we're talking about antibiotics when we say they're sensitive, and sometimes we're talking about bacteria or patients, and it's, it changes the way you interpret it. Okay, so once again, there's that picture in case you didn't see it the first time. And let's see, what's the example? All right, so once upon a time, humans became infected with Staph aureus. You know Staph aureus, we still talk about it all the time. It's a common problem because it's a common skin organism. So once upon a time, there was an organism that was Staph aureus. And once upon a time, we had penicillin, which is a beta-lactam antibiotic, and this penicillin used to kill the staph by way of the beta-lactam ring. But then the staph realized that it was going to be attacked by penicillin, so it started trying to find a way to protect itself from that antibiotic. So newer generations of Staph aureus started producing beta-lactamases. The beta-lactamases produced by the staph inactivated the penicillin's beta-lactam structure, so penicillin was no longer active against Staph aureus. So now, if you have a patient with Staph aureus and you give them penicillin, the penicillin won't work because most Staph aureus make beta-lactamases. Right? With me so far? So then, we as humanoids, not wanting to have our butt kicked by a bacteria, we developed a beta-lactamase resistant form of penicillin called methicillin. In other words, some brilliant scientist said, hey, I should be able to outsmart this bacterial enzyme beta-lactamase. So it took the penicillin and tweaked it a little bit, altered that penicillin binding, or altered the beta-lactam, and from penicillin created methicillin. Now, methicillin is resistant to beta-lactamases. So for a while, the methicillin was effective against beta-lactamase producing staph. So if you had a patient who had staph, and that staph produced beta-lactamases, you no longer gave penicillin, but you could give methicillin. The methicillin was able to destroy the Staph aureus. The Staph aureus was said to be sensitive to the methicillin. This is methicillin-sensitive Staph aureus, or MSSA, which you don't hear about very much. So we had a staph. It was resistant to penicillin, but we had a new improved form of penicillin called methicillin that was resistant to the beta-lactamases. So if the methicillin is resistant to the beta-lactamases can't inactivate it, the methicillin works, the bacteria dies, the patient is cured. Well, of course, the bacteria didn't like that. So then the bacteria found a way to become resistant to the methicillin. Because in the end, single-celled bacteria actually are smarter than us most of the time. Ultimately, this staph became resistant to methicillin, and that was known, or is known, as methicillin-resistant Staph aureus, or MRSA. And then we gave up. We gave up on trying to use beta-lactam antibiotics on staph. Instead, some other pharmaceutical company found another way to treat staph. Now we either use vancomycin, which is not a beta-lactam, or, I guess I didn't finish the or. We use either beta-lactam or a Zyvox, which is not a beta-lactam antibiotic. So the bottom line is, after the bacteria became resistant to methicillin and it became MRSA, we finally said enough. No more trying to use beta-lactam antibiotics. We have two other forms of antibiotics that we can use. Vancomycin, which does destroy the cell wall, but not with a beta-lactam. It does not block transpeptidation like your slide says. It blocks linear polymerization of the strands. The important thing is Vanco does not have a beta-lactam. It doesn't work by way of beta-lactams, so beta-lactamases can't destroy it. It's like, let's see if I can come up with one of those analogies that never works. Say you're trying to get through the door. Say The bacteria is trying to get to the door. Somebody's trying to get to the door that doesn't belong there. And like we close the door and then we deadbolt the door. First we closed it and then penicillin opened it and then we deadbolted it and methicillin opened it. We finally gave up on trying to get through the door. Now we just go through the window. So all of those actions on the door, the deadbolts and slamming it and all of that, it won't work against a bacteria that's not trying to get through a door. Yeah, I know, it wasn't my best analogy, but whatever. You get the idea, hopefully. Vancomycin is not a beta-lactam. None of the drugs with which we treat staph these days are beta-lactams. Vanco, as you know, is very narrow spectrum for staph. It really doesn't work against anything else with the possible exception of C. diff. But other than that, Vanco is really for MRSA. So these two slides are showing you the difference. Beta-lactams work on transpeptidation. We've already established that. Vanco works by blocking the linear polymerization. Remember I said that I always visualize these long strands as a braid because they're peptidoglycan strands. You have peptides and then you have glycans and they sort of weave together and form a braid, and then these braids are anchored. Well, the beta-lactams interfere with the anchors. Vancomycin interferes with the braiding process. Either way, you don't get a cell wall. Now, of course, there is more to the story. We do have forms of staph now that are vanco-resistant, and then that just stinks. Then that's what we made Zyvox for, which is a different type of antibiotic, and we'll talk about that in a few minutes. So with beta-lactam antibiotics, these were one of the very first kinds of antibiotics that we had to do the job. They're a really important piece of our antibiotic weaponry. They are very commonly used. There are some conditions that respond better to beta-lactams than anything else. Sometimes they really are the drug of choice. So the considerations with beta-lactams are, when you're trying to decide if a beta-lactam is appropriate or not, the first question is, does the bacteria have a cell wall? The overwhelming majority do. There are a few that don't. There are a few bacteria that are actually structurally more like a protozoan, that they don't really have a cell wall. They have more of a membranous structure. Some examples that you will encounter on a regular basis are Chlamydia pneumoniae, which is not like chlamydia that you think of in the reproductive tract. That's Chlamydia trachomatis, which, by the way, also doesn't have a cell wall. But Chlamydia pneumoniae is a very common organism that can cause a form of pneumonia, a fairly minor form of pneumonia. M. pneumoniae and C. pneumoniae are two very small bacteria that don't have cell walls. And then another bacteria that doesn't have a cell wall is Legionella, like Legionnaire's pneumonia. So there are bacteria that you will encounter on a regular basis that do not have cell walls. Obviously, if the bacteria doesn't have a cell wall, a drug that inhibits cell wall synthesis is not going to work. It doesn't matter. You can have the most powerful, strongest, kick-ass beta-lactam like Primaxin, which you can give to dying people and it will heal them. But if the bacteria doesn't have a cell wall, beta-lactams won't work because beta-lactams destroy the cell wall. So that's one question. And then the other question that you need to ask yourself is the bacteria a beta-lactamase producer? If we know that the bacteria we're going after has a high incidence of beta-lactamase production, like staph, for instance, that really influences our decision making. Sometimes we know, sometimes we can safely assume that the bacteria is a beta-lactamase producer. Sometimes we assume that it's not. And sometimes we don't know, and then we just have to do a risk-benefit analysis, because always when you're treating bacterial infection, you really do want to have like the closest linkage between, the closest match between the type of bacteria and the type of antibiotic. We have narrow spectrum antibiotics, which are very narrow spectrum to a specific thing. And then we have broad spectrum antibiotics, which cover many things. We don't want to just give everybody broad spectrum antibiotics. The more you use an antibiotic, the more resistance will develop to it, and then eventually the stuff won't work anymore. So if we know specifically the bug that we're treating, and there's a narrow spectrum antibiotic that will treat it, that's of course the one that we want to use. So that's why these questions matter. These questions do matter. These are the questions that like infectious disease people ask. You don't always see people paying attention to this when they're prescribing, and it's not like the patient immediately expires if you give them the antibiotic that's not the best choice. But what can either happen is they won't get better from the antibiotic. They might just get better because their immune system finally deals with it. Or they get better, but we have begun to contribute to the development of resistance. And as tempting as it is to think of resistance as something that takes like millions of exposures and years to occur and stuff like that, I gotta tell you, it's not all that long. I remember when I was first practicing, ciprofloxacin was considered a really powerful antibiotic for urinary tract infection. I mean, it was the cannon. It was the big gun you used when a patient like had urosepsis. Ciprofloxacin was actually originally designed, from what I understand, to treat cancer patients on chemotherapy because chemo destroys their immune system. If a patient on chemo gets any kind of infection, it can be very serious very fast. And so Cipro was originally designed to take care of a UTI in cancer patients. Because it was so effective and so powerful, everybody started using it for every little UTI. And now what we find is that E. coli is resistant in more than half the cases to Cipro. More than half the time, UTIs are resistant to Cipro. And that has all evolved in my career as a practicing clinician. So it's kind of scary I really try to pay attention when I can to these antibiotics, because I figure like in another 20 or 30 years when I'm old and potentially really sick and really need these things to work, I don't want everything to be resistant to it. It's unbelievable some of the resistances that have evolved just in my time as a clinician and how fast it can happen. And the thing that scares me, because of course it's all about me, the thing that scares me is that by the time I need them, they won't work anymore. So those are the things you want to ask yourself. Let's see, what else do we have here? All right, I said there were 3 ways to target drugs or to target bugs. And the next one are the protein synthesis inhibitors. So like I mentioned, bacteria is made almost entirely of protein. So interrupting protein synthesis is a good way to make your bacteria not be able to sustain themselves. So protein synthesis as a process requires 3 types of RNA: messenger RNA, ribosomal RNA, and transfer RNA. These 3 types of RNA conspire to make a new protein. The ribosomal RNA is comprised of 2 subunits, and the subunits of ribosomal RNA are characterized by how quickly they can fall through a centrifuge. I mean, I know nobody else in the world will ever ask you this, and I've really forgotten more about molecular biology than I remember. But I can tell you that when it says 30S and 50S, the S stands for Stedberg unit. I guess Dr. Stedberg was the person that counted how quickly a ribosome moved through a centrifuge. It's related to its mass, but the 30 and the 50 aren't weight. They aren't mass. They are Stedberg units. It matters, and I'll tell you why in a minute. So ribosomal RNA in bacteria is comprised of 30S and 50S ribosomal subunits. Humans do protein synthesis in very much the same way, and humans also have ribosomal RNA, but our subunits are 40S and 60S. And so the reason that matters is that the protein synthesis inhibitors that we have to treat bacterial infection, if you look them up in your drug book, you'll see that it says inhibits the 30S ribosomal subunit, inhibits the 50S ribosomal subunit. And there's one drug, I only know of one, there may be more now. There's one drug, and that is Zyvox, that we use for highly resistant Staph aureus. Zyvox is a 70S subunit inhibitor. When 30 and 50 come together as one unit, like they do at the beginning of protein synthesis, they merge and create a 70S ribosomal subunit. In humans, we have 40S's and 60S's, that will merge to form an 80S ribosomal subunit. So what's significant then is that if you have a drug that binds to the 30S or the 50S or the 70S ribosomal subunit, it won't interfere with human protein synthesis because that's not the Stedberg units of human RNA. So there's actually a couple of videos, I think, linked in your reading this week that shows you the process of protein synthesis in real time. But I also have a few pictures here. You know, it's not critical that you be able to recite the tenets of molecular biology backwards and forwards. I just want you to get how the drugs work. So, protein synthesis, remember, is the process whereby the cell copies the code that is contained in the DNA. The DNA is the master, the DNA is the original, and the DNA is wrapped up in a Watson-Crick double helix and stored in the nucleus of a cell. And then when you need to make a new protein to do whatever that cell does, the DNA unwinds, the two strands temporarily separate, you make a single-stranded copy of the code in the DNA, and those strands go off to form a protein. The DNA, comes back together, winds up, and goes back in the nucleus. So in order to make a protein, this process of unwinding and copying happens several times because you need all these types of RNA: messenger RNA, ribosomal RNA, and transfer RNA. So what happens is you copy the appropriate area of code from the DNA, the single-stranded RNA goes off to form the protein, and the DNA folds back up. You have three types of RNA that work together to make a protein. The messenger RNA, that's what this is. It's just a single strand that's stretched out, sort of like, I don't know, a template. And if you could look at this single strand under the microscope, you'd see all the little bases there. A, U, G, G, U, A, G, C, that's the other one. They're all like, all these single strands are lined up here. That's messenger RNA. The first thing that happens in protein synthesis is messenger RNA stretches out. This like signals that the process will begin. Then other RNA that was copied is your ribosomal RNA, and it folds up into these spherical structures. These are all just RNA folded up. If you unfolded these and stuck them under under a microscope, you'd see A, U, G, C, all over the place. They fold up into their little spheres, and if you drop this sphere into a centrifuge, it'll drop at, probably 30S, and the big one is the 50S. To make a protein, first you stretch out your messenger RNA, then your two ribosomal RNAs line up and anchor together on this messenger RNA. You've got your 30S and your 50S subunit. When they come together and form the initiator complex, which is the 70S ribosomal subunit, then the transfer RNAs, which are all these little hooks, they're just RNA. They're a bunch of bases lined up. The transfer RNA carry over proteins and line them up, and you start building your new protein. And this is the process, like color stained in real time. Like this is actual protein synthesis, a snapshot of it blown up and magnified by 1,000,000 times and put under a microscope. Here's your messenger RNA. It stretched out. That signaled the beginning of the process. Once your messenger RNA stretched out, your ribosomal RNAs came and lined up on the messenger RNA and united to form the initiator complex. And then when that happened, the transfer RNAs started carrying over amino acids and adding them on, one to the other. This is protein synthesis. This is what happens in the rough endoplasmic reticulum in humans, by the way, the process of protein synthesis. You just line up all your little RNAs and start building a protein until a stop code is reached, and then it stops. And then that immature protein breaks off, goes over to the Golgi apparatus where it gets modified and edited and matured, and then you've got a new protein. So this is just the same thing. Another look at it. Messenger RNA is stretched out. The ribosomal RNAs line up on it, and transfer RNAs start bringing over amino acids. and you build up those amino acids, and pretty soon your link of amino acids down here at the bottom forms a protein. Eventually this will stop, the new protein will break off, it'll go over to the Golgi where it is processed and edited and matured. Once this breaks off, everything else falls apart, gets recycled, and the process will start all over again. And here it is again in real time, and I think your video might show. It's really kind of cool the way it happens. Like, this is the real stuff, just stained and blown up a million times. Messenger RNA right here, stretched out. Ribosomes lined up, so you got two of them going on here. Here's one ribosomal unit, here's another, and the same process is happening over here. The ribosomal units came together and formed an initiator complex. Transfer RNAs, you see them floating around in the background here. They bring over amino acids and build a new protein. When the stop code is reached, this protein will break off. It will go off to be modified. The ribosomes will fall apart. They'll get recycled. The messenger RNA will break apart and get recycled, and the whole process will start all over again. And that is protein synthesis, and that is like 95% of a bacteria, just a bunch of protein constantly replenishing itself. So, some antibiotics inhibit protein synthesis. In fact, I think, if I'm not mistaken, like just from a quantity perspective, we have more protein synthesis inhibitors than any other form of antibiotic. And they do it by binding to one of the subunits, or like I said in that one example, binding to, after the two subunits come together and make the initiator, make the initiator complex, Zyvox will block that. Either way, they bind to a subunit and interfere with protein. There it is again, in case you didn't see it the last 3 times I showed you the picture. This is the artist rendering. This is the real story. I love this. I love that you can like stain these in colors and blow them up and see what's going on. They're like little spaceships. All right. So the primary consideration in deciding whether or not a protein synthesis inhibitor is the drug for you is you want to remember that they are completely unaffected by beta-lactamases. They don't work by way of beta-lactamase. So a bug can produce all of the beta-lactams in the world. These drugs are completely unaffected by that. Again, it's like beta-lactams are trying to close the door. Protein synthesis inhibitors come in through the window. So you can totally use them effectively when beta-lactamase is a problem. The downside, if it's the downside, it usually isn't, but the one thing to consider is that protein synthesis is an intracellular event. The antibiotic has to get into the cell to be able to interfere with protein synthesis. And sometimes that's not so easy to do, because remember when we looked at the cell membrane, when we looked at the structure of the cell wall, particularly in the case of gram-negative organisms, that barrier is pretty distinct, right? First you have, in gram-negatives, first you have an outer membrane, and then you have a periplasmic space, and then you have the cell wall, and then you have another periplasmic space, then an inner membrane, and when you get through all that, you're inside the cell. Even in gram-positives that aren't as complex, you still have an outer wall and then an inner membrane, and then you get to protein synthesis. So protein synthesis inhibitors can be very effective, but they have to be able to penetrate those outer barriers first to get into the cell. A protein synthesis inhibitor is not going to do you any good if it can't get into the cell to do its job. Among the many protein synthesis inhibitors that we work with, the aminoglycosides and the tetracyclines are 30S ribosomal subunit inhibitors. So if you look up in your drug book how they work and it says 30S ribosomal subunit, you're like, oh, that's clear as mud. Now, hopefully it makes a little bit more sense how it works. The aminoglycosides, which are very powerful antibiotics, this is like amikacin, streptomycin, gentamicin. These are very powerful, but they are relatively fat insoluble. They can't penetrate the cell wall and the bacterial membranes on their own. They need a separate transport mechanism to gain entry into the cell. Once they get into the cell, they are very effective, but aminoglycosides need help getting there. That's why you'll never see an aminoglycoside being given by itself. You'll always see aminoglycosides ordered with another antibiotic. Tetracyclines also bind the 30S ribosomal subunit. These also are not particularly awesome at getting through a cell wall on their own. You see these used most often. I mean, they can. They have some entry, unlike aminoglycosides. But you see tetracyclines most often used not for traditional bacteria with cell walls, but more for the atypical stuff like rickettsial disease. Like rickettsia aren't bacteria, and they don't have a cell wall. They're rickettsial. Lyme disease, for example, tetracyclines are a popular drug for that. Chlamydia, and I mean the kind of chlamydia that you get in the genitourinary tract. I mean, you get chlamydia anywhere, but we think of it as a genitourinary infection. Chlamydia is a protozoan. It's not a bacteria. It doesn't have a cell wall. So tetracyclines are effective for it. Spirochetes like syphilis, again, it's not a bacteria, it's a spirochete. And mycoplasma like Mycoplasma pneumonia. These are all organisms that we typically lump into the spectrum of bacterial infection. Mostly we lump them that way because antibiotics will treat it. But it's these tetracyclines, these protein synthesis inhibitors, they're more effective in those bacteria where they don't have to penetrate a traditional cell wall. Those medications that block the 50S ribosomal subunit that you would be familiar with, probably the ones you're most familiar with are the macrolides, right? I mean, if you've had a URI, somebody somewhere gave you a Z-Pak for it, especially if you like Z-Paks. Macrolides also include clarithromycin, which is Biaxin, and erythromycin. These drugs are 50S ribosomal subunit inhibitors, so they are excellent in blocking protein synthesis. They're a very appropriate treatment for certain infections. And we'll talk about putting them together more specifically toward the end of the discussion, but this is how they work. They bind the 50S ribosomal subunit. Clindamycin is a drug that's kind of gotten a bad rap because we tend to think of it as causing C. diff, but it doesn't really anymore. Oh, excuse me. You guys are keeping me up. Sorry. No, you're not keeping me up. Clindamycin was very popular for GI infection, for bacterial infection of the gut. And so it's a fairly broad spectrum antibiotic, and you would give it to people, and sometimes they would get C. diff, because you know C. diff is a consequence of suppression of good bacteria and overgrowth of the C. diff. Any broad-spectrum antibiotic can do that to you. Clindamycin is one of many broad-spectrum antibiotics, but the reason clindamycin kind of got this reputation is because clindamycin is it was given to people preferentially that had a sick gut anyway. So if you already have a sick gut and then we start messing around with the flora in it, the next thing you know, like C. diff just isn't too far off into the horizon. So those are your beta-lactams and your protein synthesis inhibitors. Okay, so the final way to assault or to kill bacteria is to interfere with the way that it makes new bacteria, the way that it replicates. Remember that bacteria replicate in a matter of hours, so DNA replication is really pretty fast. And the last way to interfere with this process is by way of DNA synthesis inhibitors. This is unlike the process we talked about a few minutes ago, where we're talking about protein synthesis, where a single cell is making a copy of a code from a DNA master to RNA copies in order to make protein to sustain the same bacteria. DNA synthesis is when the DNA separates to make two new sets of DNA to make daughter cells so the bacteria can actually multiply. There are not a lot of antibiotics that work that way, but the ones that do are pretty powerful. So let's see what the slide says. The final way to inhibit bacterial synthesis growth is to inhibit DNA. If bacteria can't make new DNA, new daughter cells can't be formed. There are two primary types of antibiotics that work this way. Those that you would know as trimethoprim sulfamethoxazole, most commonly marketed as either Bactrim or Septra, and also the fluoroquinolone class of antibiotics work this way as well. So this is just a brief reminder of the process of DNA replication. So, again, the master plan for the genetic code is contained in the DNA. The DNA is a double-stranded Watson-Crick double helix. This is the original DNA. It is made of base pairs. You have 4 bases, C, T, G, and A, and they pair off to make a double-stranded helix in DNA. When it's time to replicate the DNA, a series of enzymes stimulates and maintains this, and there are dozens of enzymes that do it. And they separate the two strands of the original DNA, referred to as the parent strands. These strands will separate, and then other enzymes trigger the synthesis of a new matching strand for each of the parent strands. And then you ultimately wind up with two new sets of DNA, two daughter bacteria. And this is how the stuff replicates. And again, bacteria do it very quickly. It's why you can get exposed to a bacteria, become infected, and within 12 hours be very, very sick. This multiplies very quickly, and that's how it sustains and spreads. So obviously, if you can interfere with this, you're going to shut down this infection pretty quickly. Okay, so trimethoprim sulfamethoxazole, like I said, aka Bactrim and Septra. The way that this works, because these are fairly old antibiotics, the way that these work is by interfering with folate synthesis. So in order for, and I can't back up, darn it, I wish I could, but I can't back up the slides, but you can back up the slides if you want to and look at the picture. Remember, the parent DNA has to unwind, and then you have to make a new matching strand for each parent strand. So you have to be able to incorporate bases. You have to bring in bases to synthesize the matching strand. The bases A, T, G, and C, which makes the base pairs of DNA. So if you need bases to make new DNA, and in order to synthesize bases, you need folate. That's what this diagram is showing you. In order to synthesize new DNA, which is the end product, right? You have to be able to make you have to make a base. And this is the base synthesis pathway, and you can see that you need folate. Without folate, you can't complete this pathway. So the difference between humans and bacteria is that humans don't have a folate synthesis pathway. Humans have to ingest folate. Folate is an essential amino acid. We have to eat it. It's a big part of legumes. It's in green leafy vegetables. It's really hard not to eat enough folate. You have to have like a really bad diet to not eat enough folate. If your diet is really poor, like you're an alcoholic, or if you are on medication that interferes with the absorption of folate from your food, or if you are at particularly high risk for DNA problems, like if you are pregnant and there is a risk of spina bifida in the fetus. These are all people that we administer folate to. We give them folic acid. This is ingested folate. One way or another, we have to ingest folate because we can't synthesize it. Bacteria, on the other hand, can synthesize their own folate. Bacteria make folate via the para-aminobutyric acid pathway. So obviously bacteria don't eat folate, they synthesize it. So if we want to decrease the ability of DNA to replicate by way of decreasing the synthesis of new bases so that you can't make matching strands for the DNA, then one of the things that we can do is interfere with the para-aminobutyric acid pathway. If you block synthesis of folate via this pathway, the bacteria will not be able to make new DNA, but humans are not affected because human cells don't rely on the synthesis of folate. We rely on the ingestion of it. So this slide shows you pretty cleanly how sulfamethoxazole, which is a sulfonamide, and trimethoprim, which is a trimethoprim, they interfere, they block the para-aminobutyric acid pathway in two different spots to ultimately interfere with folic acid synthesis. Makes sense, right? So you're hurting the bacterial DNA replication without hurting the human. The fluoroquinolones, which are more common, well, I don't know if they're more commonly used, they're certainly more broadly used. Bactrim is pretty much mostly for UTI. Occasionally we use it for acne, and occasionally we will use it for skin abscesses, but that's pretty much Bactrim's claim to fame. Whereas the fluoroquinolones are pretty widely used for any variety of urinary, respiratory, and skin and soft tissue infections. The fluoroquinolones work differently. They interfere with DNA replication by preventing the unwinding of that parent DNA. Again, remember that in order to replicate the DNA, the first thing that happened is that the Watson-Crick double helix of the bacterial DNA has to unwind. And of course, there's a whole series of enzymes that facilitates this unwinding. One of them is called DNA gyrase, and it is actually responsible for unwinding bacterial DNA. The fluoroquinolones are DNA gyrase inhibitors, and thankfully DNA gyrase is different, or I'm sorry, bacterial DNA gyrase is different than human DNA gyrase. So you can give fluoroquinolones, interfere with bacterial DNA unwinding without interfering with the humans. So this is just a different perspective on what we've already seen. The double-stranded double helix, like it doesn't go up any further here, but if you could go further up before gyrase comes along, this would be the classic, double-stranded DNA. And then DNA gyrase comes along and causes it to unwind. So it's not twisted up anymore. It's like unwinding a ladder. And your base pairs are anchored together by these cross beams on the ladder. There's a whole ton of other enzymes involved here. Helicase keeps it open and separates it, and then DNA polymerase and RNA polymerase comes along and makes the matching strand. DNA ligase comes along and anchors them on the lagging strand. But what we're most interested in is that the fluoroquinolones are DNA gyrase inhibitors. You can't unwind the bacterial DNA without it. And here we have the pictures blown up and stained so you can see what's going on. And you can see how it's supposed to be a double-stranded Watson-Crick double helix, and then DNA gyrase comes along and facilitates unwinding so that the stuff can separate. Ooh, here comes some fluoroquinolones on the scene to prevent unwinding. If you prevent unwinding, the things can't replicate. And that's the end of DNA replication. So it's really pretty straightforward. Again, like I said at the very beginning of the discussion, the purpose of antibiotics, or any antimicrobial, in this case antibiotics, is to find a way to kill off or prevent survival of the bacteria without preventing survival of the human host. And in bacteria, there are three general mechanisms of action. Those that inhibit the cell wall, which are mostly beta-lactam antibiotics. We do have vancomycin, which is a very specific and very narrow spectrum used to inhibit linear polymerization of those peptidoglycan strands. We have protein synthesis inhibitors, which block the bacteria's ability to sustain itself, since bacteria is almost exclusively made of protein. And then we have the DNA inhibitors, which inhibit the replication of one bacteria into its two daughter cells. That's what we got, and they each have their own considerations. So how do we put this all together clinically? I forget. Okay. Empiric selection. So in primary care, most of the time we don't have cultures. Sometimes you do, but most times you will not. Most of the time in primary care, we don't have a culture. So we select antibiotics empirically, which means we know which bacteria are most likely to be in any given body part, and we know which antibiotics are best suited to that bacteria. So we choose the antibiotic based on the bacteria that's likely to be there. We can make certain expectations in the otherwise healthy patient. If the patient's not otherwise healthy, or there are some other considerations, and of course that changes everything. But generally speaking, if you go to somebody in primary care for a UTI or a respiratory infection or an abscess or a cellulitis or conjunctivitis, or like any other itis, any other infection, diverticulitis, pick your itis, you're 9 times out of 10, we're not going to do a culture. Sometimes we will do strep throat cultures in primary care, and the efficacies for that are really up for grabs. But we certainly can't do cultures for pneumonia. We may do a urine culture for a UTI, but we're almost always going to send the patient out of the office with an antibiotic before that culture is available. In 99 out of 100 worlds, we are choosing our antibiotics empirically. And most of the time, the patient is otherwise healthy, and that can, give us some guidance in our choices. So I think there's a few examples here. Let's see. Treatment of bacterial URI. So in another world, in your clinical courses, you will certainly talk more about how you deduce that an upper respiratory infection is bacterial versus viral. Yes, in a perfect world, it's with a culture, but most of the time that doesn't happen. There are certain clinical signs and symptoms. There are certain clinical findings that can really move us in the direction of thinking that something is viral or bacterial. And in your clinical courses and in your clinical rotations, you should get some guidance that way. In the otherwise healthy patient, most upper respiratory infections are not bacterial. Most of the time they're viral and just treated symptomatically. On the other hand, if they are bacterial, they really need to be treated with antibiotics because bacterial URIs are, number one, they tend to be more serious. They tend to cause more morbidity, more illness. And in some cases, they can produce some very serious consequences. Bacterial sinusitis, for instance, it's true. 98% of the patients who come to you thinking that they have sinusitis, like half of them won't really have sinusitis, and those that do have sinusitis, it'll probably just be allergic sinusitis or viral sinusitis. But the 1 or 2% that does have bacterial sinusitis, this needs to be treated with antibiotics because the risk of it extending to orbital cellulitis or even meningitis, especially in someone who's got any risk factors for immune compromise, this is very significant. I wish I had thought to insert the pictures here. I have some pictures of a patient who actually had to have half of his face dissected away because of a sinusitis that just didn't get treated properly and caused skin necrosis. So, you could go a whole career and never see that. But man, if you miss it once, it's going to totally suck for you and your patient. So yes, most of the time URI is not bacterial, but when it is bacterial, we want to treat it properly. Pharyngitis. Most of the time will be viral. Most of the time it'll be nasopharyngitis, a viral URI. But there are people who get bacterial pharyngitis. Certainly children are more prone to strep pharyngitis because of the difference in the structure of their eustachian tube. Adults also absolutely get strep pharyngitis or other forms of bacteria in the throat. This needs to be treated properly with an antibiotic. And of course, pneumonia, which is a whole different story, obviously that has to be treated with antibiotics for the patient. Is even at risk to expire if the patient's got any underlying health problems. So, my long-winded rambling point here is that yes, URIs, when you talk about URIs in primary care, most of the time they are viral, but sometimes they're bacterial. And if they're bacterial, you don't want to miss it. By the way, pertussis, which I shared with some of you in class, I happened to pick up clinically not that long ago, but then used the wrong antibiotic, or not the wrong antibiotic, but the wrong dose of an antibiotic. But pertussis is a very serious bacterial infection of the airway, an upper respiratory infection, and its symptoms in its very early presentation look very much like a viral infection. So, I don't have the perfect answer for you. It's not like an easy job. That's why it's worth a fairly significant paycheck because it's not an easy job. And one of the things that you will have to do is distinguish among viral and bacterial URI. And one of the challenges that you'll have for yourself is to not fall in a rut. And after 5 years or 10 years, don't be so quick to just assume it's viral, or don't be so quick to just throw in antibiotics to get the patient out of the exam room because you got 4 other people waiting for you. Like, one of the challenges is every day to give every patient that level of attention and try and distinguish if this is the common viral URI or a common or less common bacterial URI. If it's bacterial, if you deduce that it's bacterial, and again, you usually don't have a culture for this, then you've got to think about the bugs that you need to cover. So this slide tells you that in primary care, in the otherwise healthy patient, if you presume a bacterial upper respiratory infection, the bacteria that you need to consider are Streptococcus pneumoniae, Haemophilus influenza, and Moraxella catarrhalis. And again, I keep throwing out this disclaimer, I know, but it's because I'm having trouble finding the line here. I'm really not trying to do the job of your clinical courses, but I just would like to give this some clinical relevance. These are the 3 most common bacteria. Actually, strep pneumonia is the most common one. H. flu is second, and Moraxella catarrhalis is a distant third. But in the otherwise immunocompetent and otherwise healthy patient, these are the 3 organisms that you need to consider. So strep pneumonia is gram-positive. The other 2 are gram-negative. So always, once you determine that you really believe this is a bacterial URI, Absent a culture, you need to cover strep pneumoniae, Haemophilus influenza, and Moraxella catarrhalis, or at least consider them. So you've got to cover both gram-positives and gram-negatives. The last bullet point on this screen tells you that almost 1/2 of Haemophilus influenza and virtually all of Moraxella catarrhalis bacteria are beta-lactamase producers. So your considerations for covering a viral URI are that strep pneumoniae, well, let's see. Okay, let me not get ahead of the slides here. If you want to treat a bacterial URI, yes, empirically, you have to cover gram-positives, which is strep pneumoniae, gram-negatives, which is H. flu and Moraxella, and consider beta-lactamase producers because almost half of your H. flu and virtually all of your MCAT are going to be beta-lactamase producers. So you got a lot to cover. Streptococcus pneumoniae. This is the most common organism in the head and neck. This is the most common in the otherwise healthy patient. It is also the least likely to resolve spontaneously and the one that makes people the sickest. Therefore, it is your primary treatment target. If you are going to cover, if you presume somebody has a bacterial URI, so you deduce that they need an antibiotics, you must cover strep. It's really malpractice not to, because it's most common, it's least likely to resolve spontaneously, and it is the one that makes people the sickest. Also, strep has a way of migrating out of the airway and migrating to other parts of the body. It can go to the heart and give you rheumatic heart disease and valvular disease. It can go to the kidneys and give you glomerulonephritis. So if you are presuming a bacterial infection in the airway, you need to treat it properly, not just to heal the pharyngitis, but to eradicate this strep so that it doesn't go on to cause valvular disease and doesn't go on to cause renal failure, glomerulonephritis and renal dysfunction. So strep pneumoniae is number one. Must cover it. I also mentioned once or twice about H. flu and MCAT. These are secondary treatment targets. They have a tendency to, well, we got more slides about it. Haemophilus influenza, your handout doesn't say this, but H. flu is more likely to resolve spontaneously, therefore it is less critical to cover, where you must cover strep. If you miss H. flu, you hope not to, but if you miss H. flu, the patient will probably survive. Haemophilus influenza is more common in smokers, like your handout says, so if you're treating people for a bacterial URI and that patient smokes, then it becomes more imperative to cover Haemophilus influenza. And again, almost half of them are beta-lactamase producers, and so a typical beta-lactam will not be effective almost half the time. So you have to ask yourself when you're choosing antibiotics, how likely is it that the patient has H. flu? And how likely is it that I have to cover everything or they're really not going to do well? Moraxella catarrhalis, much less common. It doesn't occur very often at all. It is a distant third. They are virtually all beta-lactamase producers, but they're not there very often. So if the patient is otherwise healthy and has an intact immune system, it is probably not critical that you cover Moraxella catarrhalis because it's probably not the problem, and even if it is the problem, an intact immune system will probably neutralize it. On the other hand, if the patient is immune compromised or has other chronicities or in any way is at high risk for poor outcomes, then it becomes much more imperative to cover Moraxella catarrhalis, and therefore much more important to cover all of your beta-lactamase producers. That was bacterial URI. Oh, again, I wish I could back up. If you backed up to the last slide, you'll see that at the top of the slide it says treatment of bacterial upper respiratory infection, URI. And so, again, just to recap while I transition to this slide, bacterial URIs are usually strep. H. flu is the number 2 likely organism and more common in smokers. MCAT is a very distant third. Half of the H flu and all of the MCAT are beta-lactamase producers, so if you really feel like you have to cover them, you'll want to cover beta-lactamase producers as well. What is the clinical significance of this? Well, if like somebody just like say, I don't know, a 10-year-old rolls into your office and you really believe the kid has bacterial pharyngitis, it's probably strep. So the most compelling thing to cover is strep pneumoniae. Is the 10-year-old a smoker? We hope not. So it's significantly less likely that it's Haemophilus influenza, and it's really unlikely that it's Moraxella catarrhalis. So when you ask yourself what you have to cover here, what you have to cover is strep. If you can cover H flu, okay, it might be that, but it's probably not. And it's really probably not Moraxella catarrhalis. As it happens, most of the antibiotics that we have are broad spectrum enough that you can cover strep and cover H flu and even cover beta-lactamase producers if you think you have to. The reason that you will see amoxicillin, for instance, very commonly used in kids with strep throat, it's a combination of appropriate coverage and practical application. Amoxicillin will cover strep. It will cover the half of H flus that don't make beta-lactamase. Now, amoxicillin alone will not cover beta-lactamase producers. Amoxicillin is beta-lactamase sensitive. But in your average garden variety 5 or 10-year-old, strep is probably the organism. H flu is much less likely, and if it occurs, it's more likely to heal spontaneously. So covering H flu isn't as imperative. So you give the amoxicillin, it'll cover strep, it'll cover half the H flu. It won't cover MCAT because it doesn't cover the beta-lactamase producers, but in a 5 or 10-year-old, honestly, beta-lactamase producing H flu and MCAT are really unlikely. Right? Now, if it's a kid with chronic illness, a kid with immune compromise, well, then the risk for poor outcomes if you miss a beta-lactamase producer becomes very significant. If the kid has impaired immune function, it's much less likely to heal on its own. So now we really want to cover not only strep, but H flu and the beta-lactamase producers and Moraxella catarrhalis. So now you don't want to just give amoxicillin, you want to give amoxicillin with a beta-lactamase inhibitor like clavulanic acid, which is administered as augmentin. So the otherwise healthy 5 or 10-year-old with no other medical problems, you will very commonly see given amoxicillin. The 5 or 10-year-old with any other medical problems or immune compromise or frequent pharyngitis, you'll see them given augmentin. Augmentin covers the rest of the H flus and all of the MCATs. So I hope that makes sense. I mean, it's just a way to start the discussion. It's just a beginning of how you make this analysis. That's an upper respiratory infection. Now we're talking about treatment of community-acquired pneumonia. So this is lower respiratory infection. The organisms that infect the lower airways are a little bit different than the organisms that affect the upper airways. Now, in the lung, the bugs we need to consider are strep pneumoniae, Haemophilus influenza. I'm going to sneeze. Bless me, I'll just talk about URIs, I guess. Anyway, in the lower airway, we need to cover strep pneumoniae, H flu. Moraxella catarrhalis doesn't occur nearly as often in the lower airway. The organisms that you see more often in the lung are M. pneumoniae and C. pneumoniae, and these last two are collectively referred to as atypical pathogens. They're atypical, they're different, and so they change the way that we consider antibiotic therapy. M. pneumoniae and C. pneumoniae do not have a cell wall like the second bullet point says, and so now we can't kill them with a cell wall synthesis inhibitor, which means no beta-lactam. So remember a minute ago when we were talking about upper respiratory infection, and I said strep is your most common treatment target, H flu a second, not a great second, and then MCAT a big third. So I said that amoxicillin would cover the strep and some of the H flus, and that augmentin, which is amoxicillin with a beta-lactamase inhibitor, would cover everything else. So you could treat a very serious upper respiratory infection with augmentin and feel comfortable that you are covering the primary organisms. But in the lower airway, the difference here is there's no more Axella catarrhalis. What you've got are the atypicals that don't have a cell wall. So forget the amoxicillin and forget the augmentin. They won't cover all of these organisms. Even the most powerful beta-lactam in the world will not provide adequate coverage because these last two, M. pneumoniae and C. pneumoniae, which are pretty common in lower respiratory infection, don't have a cell wall. So next slide says, because two of the bacteria that we have to cover don't have cell walls, right, you should never see a beta-lactam used alone to treat community-acquired pneumonia. I hope that you never do. If you do, just take the lesson that that's not the thing that you want to do. Unless you have a cultured organism. Obviously, if you have a culture that tells you what organism you're treating, then the rest of this all goes out the window, because everything we're talking about here is empiric therapy. These are the foundations for empiric therapy. If you happen to have a culture for pneumonia, if you were lucky enough to get a really good sputum from the lung in your patient, then fine. Then if the patient has a bacterial infection that is susceptible to a beta-lactam, of course then you're going to use a beta-lactam antibiotic. In fact, if we have time, I guess I have all the time in the world, I'll tell you a little story about that in a minute. But forgetting that, because most times in primary care we do not have a culture, most times we're treating empirically, so we have to cover strep, H-flu, consider beta-lactamase production, and the atypicals which don't have a cell wall. That's why, last bullet point here, that's why choice of drugs for the otherwise healthy patient, according to our evidence-based guidelines, are either a macrolide like erythromycin, azithromycin, or clarithromycin, which is erythromycin, or zithromax like a Z-Pak, or clarithromycin is Biaxin. We can either use a macrolide or doxycycline. Neither of these are beta-lactams. Neither of these inhibit the cell wall. These are both protein synthesis inhibitors. So since they're protein synthesis inhibitors, they will kill any form of bacteria that has to make protein, which is all of them. And so in the otherwise healthy patient, again, like you or like me, that you have community-acquired pneumonia, a macrolide or doxycycline will cover strep, H-flu, and it'll cover all the H-flus because since it's not a beta-lactam, it is totally impervious to beta-lactamases. Beta-lactamases won't affect them at all. So strep, all the H-flus, and it will cover the atypicals. Now the one little fly in the ointment here, and again, your clinical courses will give you more detail about that. There is one risk in giving people with community-acquired pneumonia a macrolide or a doxycycline, and that is because there is a certain subset of the population who is at risk for drug-resistant streptococcus. And like with a bacterial URI, bacterial lower respiratory infection, or LRI, aka pneumonia, the most common organism is still strep. Just like in the upper airway, strep is the most common organism. A macrolide or doxy will kill regular strep, but there are some people who are at risk for drug-resistant strep. And I think in your next page of the handout it will tell you that. But people who are at risk for drug-resistant strep, a macrolide or doxycycline won't cover that. Then we have to manage them a little bit differently. As it happens, the best drugs for drug-resistant strep is a high-dose beta-lactam, which is great because we can give a high-dose beta-lactam, but that beta-lactam won't cover the atypicals. And so if you have someone that has pneumonia and you are concerned about risk for drug-resistant strep, now you have to cover drug-resistant strep and H-flu and beta-lactamase producers and the atypicals. And so it just makes some differences in your choices. If you give a high-dose beta-lactam for drug-resistant strep, we have to give a second drug to cover the atypicals because atypicals don't have a cell wall and beta-lactams can't affect them. That's why and I know these guidelines are 9 years old, but they're the latest guidelines we have for the treatment of community-acquired pneumonia. The Infectious Disease Society of America and the American Thoracic Society came together to help me 7 or 9 years ago, right? what year is this? 2016. Yeah, 9 years ago. God, I can't believe it's been 9 years. 9 years ago, they came together and published these guidelines on how to assess and diagnose and manage and follow up community-acquired pneumonia. And what they say is that obviously this is a long guideline, so there's more to it than that. I'm just trying to consolidate here, again, to give it some clinical relevance. This isn't like an all-inclusive discussion of the management of pneumonia. But what these guidelines tell us is that if you have a patient with community-acquired pneumonia, obviously hospital-acquired pneumonia that some of you may be more familiar with is totally different. But community-acquired pneumonia, these guidelines say that if the patient is previously healthy, in other words, no comorbidities, which means no risk for poor outcomes, like no COPD, no congestive heart failure, no coronary artery disease, no diabetes, all of those things that make patients higher risk patients. If the patient is previously healthy and under 60 years old, there is not a high risk for drug-resistant strep. That means that your primary treatment targets in that patient are strep pneumoniae, H. flu, beta-lactamase producers, and the atypicals. And so in these patients, because they're not at high risk for drug-resistant strep, you can give the patient a macrolide or a doxycycline. Macrolides or doxycycline will cover strep, not drug resistance, but you're not worried about drug resistance here. They'll cover strep, they'll cover H. flu, and they'll get the beta-lactamase producers because they're not beta-lactam antibiotics, so they're not sensitive to beta-lactamases. And the macrolide and doxy will get the atypicals because they don't have a cell wall, because the macrolides and doxy are not cell wall inhibitors, they're protein synthesis inhibitors. That's that bullet point. These guidelines then go on to say that if the patient is at high risk for drug-resistant strep, and a high-risk patient for drug-resistant strep can be many things, anybody over 60 is at high risk for drug-resistant strep. Anyone with a significant comorbidity, like a cardiopulmonary comorbidity or diabetes or cancer, or any serious chronic illness. Also, your handout doesn't say it, but anyone who has been treated with antibiotics for any reason, any antibiotic for any reason in the last 3 months is also at high risk for drug-resistant strep. Anybody with high risk for drug-resistant strep now has to be treated to cover both the drug-resistant strep and the beta-lactamase producers and the atypicals, which means either a high-dose beta-lactam, because the high-dose beta-lactam is the way we treat the drug-resistant strep. But if you give them a beta-lactam, even high dose, you have to add the protein synthesis inhibitor macrolide or doxycycline to cover the atypicals. So if you're treating drug-resistant strep with a high-dose beta-lactam, you have to add a second agent that's not a beta-lactam to cover the atypicals. Now, your slide doesn't say it, but you do have another alternative here, and that is a respiratory fluoroquinolone. Remember, respiratory fluoroquinolones are DNA synthesis inhibitors. They are rather powerful, so the fluoroquinolones will cover drug-resistant strep. Because they're not beta-lactams, they will cover beta-lactamase producing bacteria. And because they're not beta-lactamase producers, they will cover the atypicals. So your choices for a patient who's high risk for drug-resistant strep is either a respiratory fluoroquinolone, which is a DNA synthesis inhibitor, which covers everything. One drug covers everything. Or if you don't want to use a fluoroquinolone, you have to use either a high-dose beta-lactam to cover the drug-resistant strep, and a macrolide or a doxy to cover the atypicals. So you might say to yourself, Self, why would I ever use 2 drugs when I could just use one? Why not just use a fluoroquinolone instead of a high-dose beta-lactam, macrolide, or doxy combination? And the answer is usually side effects and cost. Believe it or not, the combination is cheaper than the fluoroquinolones. They're expensive, and some people have pretty significant side effects to fluoroquinolone. So there are reasons to use one over the other, but again, just trying to give you some clinical relevance here. I'm sure you'll hear more about it in your clinical courses, and you will certainly hear more about it in your board review. So the story I was going to tell you about all of this, we're done talking about pneumonia now. Don't worry, slide set almost over. Wow. Yep, slide set almost over. But I emphasized a few minutes ago that we're talking here about empiric selections because in primary care you don't usually have a culture. And these empiric selections are based on guidelines, 2007 IDSA or ATS, and guidelines are based on what usually happens. You most of the time you will not go wrong with a guideline, but every now and then you will. So I have one story to give you an example of how guidelines, they're a good place to start, but they're not always in everything. A couple years ago, when I used to have the practice in Las Vegas, I had a lady come in January. January is always like an interesting time in primary care because it's when it's open enrollment for all the new plans. So everybody changes, not everybody, but lots of people change their insurance, like they get new insurance or they change their plan in January. And even more interesting is the Medicare HMOs. Medicare HMOs really aggressively enroll seniors, and then they get their new plan effective as of January 1st. So as a result, in January, you often get a lot of new patients, and if you see much geriatrics, you will get a whole slew of older patients who this is their first year with their Medicare HMO, which means they don't have a copay, which means they don't pay for anything. So they're going to show up people that haven't, seen primary care for years and years, or people who haven't gone because they didn't have any insurance, or they did but they had a copay or whatever. Now they don't have any copay, so now they're going to come in and like land on you with all their problems. And that's what happened I think it was January of 2012. I had a patient come into the office. She is a taxi driver, and she was like 70, I guess 75, and she had just gotten this Medicare HMO, and she comes in as a new patient, and she can't breathe. She comes in, and she's like, "Oh, honey, I think I'm going to die. I just can't breathe." And I'm looking at her thinking, like, I think you're going to die too, because she really can't breathe. She's like very animated. Like everything about her was kind of larger than life. She had like this bright red dyed hair, which, can look awesome, but at 75, it did catch her eye as not exactly being natural. Just, every time she waved her arms, it was like very expansive. Her sighs were very exaggerated. It was hard to tell how much of it was she just couldn't breathe and how much it was a sigh. Very nice lady, but just everything was very exaggerated, and she obviously had not been a regular customer of primary care. So she comes in and she's like, "Oh, honey, I can't breathe." So we go in the exam room and she's like, "Oh, I couldn't tell last time I saw a doctor. I hate doctors." So she goes on to tell me that she gets all of her primary care in South America. So she drives a taxi. She's single. She has a boyfriend, but, she's like single. She saves all her money, and once a year she goes on a vacation to South America, and that's where she gets her primary care. So she starts unloading her purse in the exam room, and there's like a Proventil inhaler, and there's a bottle of digoxin, and there's a bottle of levothyroxine, and there's a pack of cigarettes, and what else was there? I feel like there was one other thing I can't remember. I don't know, like she starts unloading some stuff, and she's telling me that she tells me she's had asthma and COPD forever. As long as she can remember, she's had both asthma and COPD. She gets her inhalers in South America. She got put on DIG by a hotel doctor in Colombia because of something about her heart. And the thyroid. She was told she had an underactive thyroid, like on one of her vacations, and so she buys her thyroid hormone over the counter in some South American country. So this is her story, but now she can't breathe, so now she's here to see me. So as we go into her medical history, I don't know. Obviously, it's a respiratory thing. She tells me she has asthma and COPD, right? So we did spirometry in the office, and actually she had spirometric criteria for both COPD and an asthma exacerbation. So I really wasn't sure what was going on. Her lung exam was really complicated. The auscultation was just a kind of junky. The one thing I was confident in was it wasn't fluid. There was some sort of airway, like not fluid in the airway, but some sort of other airway dysfunction. But I was actually sitting there palpating tactile fremitus, trying to get a sense of what was going wrong, and it was definitely different. I truly forget now which side. Like one side had clearly stronger tactile fremitus than the other side, but I didn't know if she had increased fremitus because she had pneumonia on one side, or if that side was normal and she had decreased fremitus on the other side because she was having a COPD exacerbation. So it was just really hard to figure out what was going on with her. I did draw some blood, I had some blood drawn to send out to the lab, and we did an EKG, which interestingly enough showed AFib with a controlled ventricular response. So, her DIG seemed to be doing the job, whatever it was for the moment. So recognizing that the respiratory thing was the biggest problem. I didn't know whether she had an asthma exacerbation, a COPD exacerbation, pneumonia, or all of the above. And it really was kind of like a house moment. Now, keeping in mind that pneumonia in the older adult, they're much less likely to be febrile. Tachypnea is considered a really pathognomonic hallmark of pneumonia in the elderly adult. And believe me, this lady was definitely tachypnic, but she was not febrile. But that certainly doesn't disregard pneumonia in older population. So anyways, I didn't know what to do. I really wanted her to go to a hospital, but she was absolutely dead set against it. Just no, she would not go, period, end of story. So I just covered everything. I gave her a prescription for a respiratory fluoroquinolone because they really are like the best stuff for a community-acquired pneumonia. I gave her a prescription for Avelox. I also put her on 5 days of steroids in the event that it was a COPD or an asthma exacerbation. And I gave her a new Preventil inhaler and asked her to, go home and use all of that stuff and follow up with me by phone in a day or two and follow up in the office in 3 days, because you got to at least give it that long, to get any appreciable improvement. And then, of course, told her if things got worse or this didn't get any better or she woke up in the middle of the night, couldn't breathe, to call 911, whatever. But that was the plan. I sent her home with steroids. I mean, it was kind of like a house episode. You don't want to give her steroids because if she has pneumonia, you don't want to suppress the immune response. But on the other hand, if it's a COPD or asthma exacerbation, she has to have steroids, So I just gave her everything, crossed my fingers, and sent her home. These are like the scary patients. These are the ones that you go home at night and hope you covered everything, and then you go back to work in the morning and have a message that they were admitted to the hospital overnight and they're on an event. Believe me, these older patients with respiratory, like chronic disease, if they get pneumonia, they can just crap out on a dime. So these are scary patients. But anyway, that's what I did. So the next day, I don't remember if I called her the next day or the day after. I did talk to her, certainly within 48 hours, and she did not feel any better. I must have talked to her the next day and she didn't feel any better. And I said, all right, well, keep your appointment she was coming back 3 days after the initial appointment. I said, come in and we'll see what's going on there. So she came in 3 days. So say she came in on a Monday the first time, now it's a Thursday. Now she's worse. Now she looks just as crappy as she did, but now she can't even perform spirometry. She can't do the spirometer. She can't lay down on the exam table. So now I tell her, you got to go to a hospital. There's nothing we can do about it. You got to go to a hospital. I want to call an ambulance for you. And she's like, no, call my boyfriend. So I called her boyfriend, and he was mad. He figured if she had to go to a hospital that bad, why didn't she have an ambulance? But she wanted him. So anyway, he showed up, and it was all very dysfunctional. He shows up and takes her to the hospital, where a friend of mine is a pulmonologist, and I try to send all my patients to him when I can because I know he'll always tell me stuff. So I called him and said she was coming and that I wasn't sure what was wrong, but please figure it out. So she spends 3 days in the hospital, and guess what she gets? An IV version of everything I had just given her. She got IV levofloxacin, she got IV steroids, she got nebulizer treatments every 4 hours around the clock, a CT of the chest, which didn't really demonstrate anything, and she refused a cardiac workup, which good for her because she really didn't have any need for a cardiac workup. So after 3 days of IV steroids and 3 days of IV antibiotics, she gets discharged to home to finish the regimen orally and instructions to follow up with me. Thanks. So she comes back in, I don't know, she was in the hospital for 3 days, and I think she was home for another 2 or 3. So she comes back into me after that. She looks as bad as she ever did. She looks as bad as she did the first time I saw her and the second time I saw her. And so we're sitting there in the office, and she's like, oh my God, honey, I think I'm going to die. I don't know what's going on. They can't figure it out in the hospital. And the CT of the chest was really unequivocal. In fact, I think it did not, the CT said it did not support COPD, but she was discharged with a diagnosis of COPD exacerbation. So not with pneumonia anyway. So, there we are sitting there in the office, and she's like, I don't know what to do. And I'm thinking, God, I don't know what to do because I didn't know what to do. What else is there to do? So while we're sitting there talking, she coughs up this giant hocker, this giant, thick, tan, inspissated mucus. She coughs up a big one. And it's in her mouth, and she's going, And I said, hold on. So I grabbed a specimen container right out of the drawer, right in the room, thank God, pulled a specimen container out and said, go, hock it up right there. So she spits this big specimen in the container, and obviously we're not going to send her back to the hospital because it, didn't help her at all. She wouldn't go anyway, but I didn't want to send her because she didn't really need to be there. There was just nothing to do except keep doing what she was doing. And I said, let me send this sputum out and let's just go have another x-ray in as an outpatient. Because, even though a CT certainly should have demonstrated whatever was wrong, sometimes if patients are really dehydrated, which happens to them when they're really tachypnic for several days or a week, it's not as easy to see areas of consolidation on radiography because the consolidation needs fluid to fluff it up. And so anyway, sometimes when patients are dry, the x-ray isn't really as diagnostic. I know that the CT was negative, and I don't know. I never did figure out why it was. But anyway, because I didn't know what to do and because I wanted to do something, I sent out the sputum for a culture and had her go to Desert Radiology for another x-ray. So she goes home, and I tell her, we're going to catch up in a day or two. So she goes home, and the one interesting thing was that when she got discharged from the hospital, she was dispensed a different looking kind of albuterol inhaler. I had never seen it before. It's kind of weird. She didn't know how to use it, so she had not been using her albuterol. Actually, I didn't know how to use it. We had to sit there and figure it out. So at least going home, she would know how to use her new albuterol inhaler. So she goes home. So the next day, I get back the preliminary culture and sensitivity on the sputum, and while I'm standing there looking at it, the Desert Radiology calls and says, "Hey, your patient has pneumonia." And I was like, I know, because I'm looking at the sensitivity report that says she's got over 100,000 colonies of E. coli in her lung. And I'm like standing there with this odd look on my face going like, how did she get E. coli in her lung unless she's had like some really freaky vacations in South America? I mean, we know where E. coli lives, and it doesn't usually find its way into your lung, unless you're like bedridden or aspirate or something like that, which she clearly was not. But anyway, at least I had a cause and I had a sensitivity report, and guess what? It was resistant to fluoroquinolones, because fluoroquinolones really aren't the best thing for E. coli anyway. E. coli is not a common organism in community-acquired pneumonia, so you can follow those guidelines for community-acquired pneumonia to the letter and not cover E. coli. Well, we're covering our strep, H. flu, and atypicals, right? So she was resistant to fluoroquinolones, but she was sensitive to some beta-lactams. She was resistant to many. This was a pretty resistant bug, but it was sensitive to Rocephin. Rocephin was the only thing that I could give her that didn't have to be IV. I could give it to her IM. So I called her back and said, hey, I think we got this figured out. Come on in now and get a shot. So I told her, when she came back in, I said, best world, you go to the hospital and get treated for this. And she's like, no, I'm not going to the hospital. So I had her come in every day for 3 days to get a gram of Rocephin IM and then put her on an oral cephalosporin that was consistent with ceftriaxone coverage. And I swear to God, within the 3 days of the Rocephin, this lady looked better than she had since the moment I met her. And by the time she finished her course of cephalosporins, she looked normal. She appeared like completely recovered. She felt great. She went back on to do her thing. I didn't see her again until many months later when she came in for a UTI. She had a UTI because she had a new boyfriend because she fired her old boyfriend, the one that didn't want to take her to the hospital. That's what she said. She's like, I fired my old boyfriend, but now I have a new one. And she had a UTI because she was 75, remember, and her new boyfriend was like 50-something. So she was being pretty active. So now she tried to give me the details. I was like, nope, that's okay. You probably have a urinary tract infection. So again, E. coli was just the bane of her existence. But at least this time it was in the part of the body we expected it to be in. But the reason I tell you that is because it was an unusual circumstance. You don't typically expect E. coli in the airway. At least, I didn't expect E. coli in the airway. I did call the pulmonary consultant. I said, hey, how did this lady's pneumonia not show up on a CAT scan? And how did she get E. coli in her airway? And he's like, Sally, I don't know why it wasn't on a CAT scan. Sometimes it's not. Sometimes you just don't know. Diagnostic tests are not the be-all, end-all. That really was a wake-up call for me that if you think something is going on and you do the diagnostic test that you usually do and the test comes back negative, you can't completely discount that diagnosis. If you can't figure out what's going on, and if the patient is still symptomatic, and if it still really seems like that diagnosis that you thought it was, you just have to work it up again. You just have to keep at it. There's just all kinds of tragedies that can happen when you think there's a problem, you do a test, the test is negative, you rule it out and never consider it again. So that was one lesson for me. Even after all these years, once the CAT scan didn't demonstrate pneumonia, I just really didn't even think about it again. Only grabbed that sputum because she coughed it up right in front of me and I didn't know what else to do. So anyway, he's like, I don't know. Sometimes pneumonia's not on the CAT scan. That's why we cover her with antibiotics. But in her very unusual and unfortunate case, the antibiotic that we cover people with didn't cover her organism. And then the other thing, I said, how does she get E. coli? She's like ambulatory, she's walkie-talkie, as they say. And he was like, Sally, we all aspirate. When people say, oh, Sally, I was like, I know they're going to make me feel stupid. He's like, we all aspirate all the time. We all aspirate every day. It's just that she has years of poorly controlled asthma and poorly controlled COPD under her belt. So she has probably a badly inflamed airway. And that badly inflamed airway was just like a totally fertile ground for that aspirate. So, when you and I aspirate, we aspirate gastric contents into our lung, we cough it out, or we just metabolize and excrete it, or our immune defenses get to it before it causes any problems because we have pretty normal airways. But if you're 75 and only get your health care from hotel doctors in Colombia, and you smoke and have had COPD and asthma for who knows how long, of course your airway is a nightmare. Your airway is a cobblestone inflamed nightmare. So if you aspirate, you're much more likely to have consequences of it, to get infectious disease. So it was a really interesting case. I mean, it really sort of reopened my eyes to the fact that, yes, guidelines are guidelines, and a lot of the time they will cover the thing and be right. But you really have to understand what's going on with the patient and make an analysis to make sure you cover your tracks. And I guess if I had stopped to think for a minute, that steroids just were not helping her at all, the logical deduction was that she had an infectious process that the antibiotics weren't covering. But I just didn't go there. I was just like, well, she's on a fluoroquinolone. How much better does it get for community-acquired pneumonia? And in 99 out of 100 worlds, the fluoroquinolone will do it. But in her world, it didn't. So guidelines are awesome. You can't go wrong. But if all right, now we got bacterial skin infections. So back in the spirit of empiric stuff, bacterial skin infections are usually strep or staph. Staph is usually what's going on when you have a fluctuant abscess, like where pus can come out. This is one of the more satisfying things to do in primary care, is drain one of these things. Whereas cellulitis isn't... it's not fluctuant. There's not a collection of pus, but there is a more disseminated bacterial infection in the dermis. Cellulitis is more often strep. Sometimes it can be staph, but statistically it's strep, and statistically this is staph. That's why when you have to cover these with an antibiotic, with this one you will cover for staph, and with this one you will cover for strep. If the patient doesn't demonstrate clinical improvement in 48 to 72 hours, then you cover the other one. Then you think outside the box. And again, I'm talking about the otherwise healthy patient. Cellulitis is not at all uncommon as a gram-negative organism like Pseudomonas in people who are immune compromised or people on chemotherapy. So like if somebody shows up and maybe they have risk factors for HIV/AIDS, and they have cellulitis, don't just attribute it to strep. Ask yourself, are they immune compromised? Do a CBC and see what the white count and the differential looks like. It might be a gram-negative infection. But all other things being equal, the otherwise healthy patient, this one is usually staph, and this one is usually strep. So there you go. Abscesses are almost always due to staph. Abscesses are almost always due to staph. This is a presumed organism. So if you have to treat with antibiotics, your primary treatment target is staph. Keeping in mind that the most important thing to do, I thought your handout would say it, but it doesn't. Most important thing to do with an abscess is drain it. You must drain it. You need to anesthetize it if you can, and then stick a big old number 11 blade in there and open that thing up and drain it out. There's lots of awesome YouTube videos to show you how this is done. But abscesses must be drained. That is the primary treatment, is adequate drainage and irrigation of the abscess. The only times that you need to use antibiotics with the abscess is if the patient has signs of systemic infection, like a fever or an elevated, like a shift to the left, an elevated white blood cell differential, like if their total white blood cell count is elevated appreciably, or their neutrophil count is elevated, or if on physical exam there is a lot of proximal tracking or streaking. Like a little abscess is one thing. But an abscess where the redness is tracking up, like, toward the body of the patient, like up the arm or up the leg or whatever, then you have to cover with antibiotics. So always, always IND. Whatever anybody ever tells you in your clinical rotations, it's always supposed to be IND'd. You will see people not drain small abscesses. You should drain them. Will they get better with antibiotics? Sometimes, probably. Sometimes they'll get better on their own, but the standard of care is to drain them. If you think there is disseminated infection as evidenced by fever or all the things I just said, then you want to cover staph with antibiotics. So these are your options. The CDC has a publication on abscess treatment and the treatment of MSSA and MRSA. And remember a little while ago we talked about the differences between MSSA and MRSA. Most Staph aureus in the community is just generally regarded as methicillin resistant, so we cover MRSA. For less severe, like less serious abscesses in the otherwise healthy patient, if you think you need an antibiotic, Bactrim or clindamycin are the ones to use. Those are the first choices. You will see people sometimes not use antibiotics at all, and that's very appropriate. Sometimes you'll see them add Bactrim and add rifampin to it, but the standard of care is Bactrim double strength or clindamycin. If you have people who are sicker, maybe have more serious systemic symptoms like, significant fever, or they're immune compromised, say from IV drug abuse or debilitated cachectic, stuff like that. Or if they have recurrent staph, or they have staph that has disseminated, like not just the abscess, but it's to, a visceral organ or something, those are the people for whom Zyvox or IV Vanco is indicated. But it's because you want to cover staph. Cellulitis, on the other hand, the primary treatment target is strep. So when you're treating this empirically, the appropriate drug choices are those that are better suited to strep, which Bactrim and Clinda would be okay, honestly. But Bactrim and Zyvox and Vanco are not anti-strep drugs. They're anti-staph drugs. When you are targeting strep, penicillin, dicloxacillin, which is a methicillin-sensitive, form, or maybe I didn't mention that, but dicloxacillin is the oral version of methicillin, basically. If the patient is penicillin allergic, you can give erythromycin. That covers strep. Some of the first-generation cephalosporins will cover strep. You need to look it up. And for that matter, some of the broader cephalosporins, like Rosefin, will also cover strep. And the fluoroquinolones are not typically your first choice, but they are an option. And then finally, the last slide we have about empiric coverage are the urinary tract infections. And again, you know that the most common organism for a UTI is E. coli. And so that's what we're covering when we don't know. And the standard of care is Bactrim, sulfamethoxazole trimethoprim, for uncomplicated UTI, like a woman of childbearing age with an uncomplicated UTI. The drug of choice is Bactrim DS, 1 tablet POTID or BID. It has excellent coverage for E. coli. You can use a urinary fluoroquinolone, and that's the next level of care if the patient is has a resistance or an allergy to Bactrim, or regionally there's a resistance to Bactrim, or if the urinary infection is more serious, urinary fluoroquinolone. And then in some patients that can't take the other drugs, like pregnant patients, you can use a cephalosporin. But again, this is empiric therapy for the otherwise healthy patient. Remember that if a patient has had any risk factor for introducing bacteria from the external environment to the internal environment, then they are at higher risk for staph, or strep for that matter, and you may need to cover for a gram-positive organism. People like, for instance, with an indwelling Foley, we almost always presume that it's a gram-positive organism. So I hope I didn't stray too far afield there. Just, my primary goal is that you understand how they work, but I wanted to give you some discussion about how the clinical relevance. Often in primary care, people will just use antibiotics based on guidelines and can't really articulate for you necessarily why they are the best antibiotics. My hope is for all of us to just remain cognizant of the fact that guidelines most of the time are okay, but not always. And like in the case of my patient with pneumonia, if a guideline-driven approach isn't doing the job, we have to remember the underlying problems and the underlying mechanisms of action and think outside the box a little bit. All right, that's all I got. See you next week.